Hello, everyone. I'm really happy to be here this morning and to be part of this great event. So thank you very much for inviting me. So in my hospital practice, I frequently see patients with Parkinson's disease, and I typically get two types of referrals. The first one is related to questions about cognitive functioning in an individual with Parkinson's disease. So often these patients are experiencing some sorts of difficulties in their everyday life, and either the patient or sometimes the family members are concerned about their functioning. So my job is to provide a detailed neuropsychological assessment to determine if the person does have difficulties, and if so, what kinds of problems they're having. So my talk today is actually going to really delve into these specific abilities that I assess and that can be affected in Parkinson's disease. The second type of referral that I get is actually related to deep brain stimulation surgery. So before the surgery, a routine part of the process is to assess patients to make sure that they're actually good candidates for the surgery. And my job, again, is to evaluate patients with cognitive tests to determine if there's any neuropsychological concerns before they're actually accepted to have the surgery. And I'm going to talk a little bit more about the whole deep brain stimulation topic as well in my talk today. Okay, so let's get started. So many people who think about Parkinson's disease think about motor problems, right? So things like tremor, rigidity, akinesia or bradykinesia, and really what that is, that's just a medical term for reduced or slowed movement. Also postural instability is another term that's used, and it's really difficulty maintaining your body in a stable or a balanced position, and that can lead to difficulty with falls and walking, etc. Okay, and also some other common characteristics related to the motor changes would include things like hypophonia or a softer voice, reduced facial expression that we sometimes see, micrographia, which is very small handwriting, and stooped posture. And certainly these are the common physical characteristics of the disease, and arguably the most obvious characteristics to an observer. And there's also some common non-motor symptoms that are associated with Parkinson's disease. And these symptoms have a very significant impact upon functioning and quality of life as well. So some of these physical non-motor symptoms would include things like difficulty with swallowing, various kinds of sleep disturbances and fatigue, changes in functioning of the autonomic nervous system. So these are things like problems with blood pressure or bowel and bladder control. And reduced sense of smell is actually a very common feature that we see in Parkinson's disease. But today I'm going to really focus on two other non-motor issues which can have wide-ranging impact on people. And these, of course, are the cognitive difficulties and the emotional and behavioral changes. And as I said, these changes can be just as traumatic and frustrating as any of those other physical symptoms that I've mentioned. And so it's really important that we talk about them and that we understand them. Okay, so more specifically, these are the general questions that I'm going to be addressing today in my talk. So first of all, what are the typical cognitive changes that we see in Parkinson's disease? And also, what defines dementia? At what point do the cognitive changes become a dementia? I'm also going to talk about the emotional changes that we see, as I've mentioned. And I'm also going to talk a little bit about neuropsychological assessment in regard to DBS surgery. And finally, I also want to touch a little bit on the treatments and strategies to cope with these cognitive and emotional changes. Okay, before we get right into the cognitive abilities, though, I do want to do a very quick review first about what's going on neuropathologically in the brain. As I'm sure all of you know, Parkinson's disease is typically associated with dysfunction of a brain structure in the brain called the basal ganglia. And this structure is located very deep within the brain, and it's responsible for the initiation and control of movement, but it's also involved in a lot of other functioning as well. So in fact, it receives inputs from many areas of the brain, and it sends signals back out to those parts of the brain too. So some of the most important areas of the brain that are connected to the basal ganglia have to do with the following things. So certainly motor control, that one's pretty obvious. And also control of eye movements too. So sometimes eye movements are affected in Parkinson's disease. But interestingly, the basal ganglia is also quite connected with areas of the brain involved in cognitive functioning and emotional functioning as well. So this explains why a person with Parkinson's disease can have such varied symptoms and not just movement problems. Okay, so what's actually happening in the brain, in the basal ganglia to cause all of these symptoms we're talking about? I know this is probably a review for everyone, but I'll just touch on it briefly. There's two primary neuropathological problems that are happening. The first major problem is a reduction in a neurochemical or neurotransmitter called dopamine. And this is because neurons in the basal ganglia have degenerated, and those are the ones that produce the dopamine. And it's the reduction in dopamine, of course, which is the major reason for the symptoms that are experienced in Parkinson's disease, and why the main treatment, levodopa, really works, because it basically increases the levels of dopamine back in the brain. The second problem that's going on is the appearance of an abnormal protein that is deposited within the brain cells in the basal ganglia and other parts of the brain as well. And these abnormal deposits are called Lewy bodies. And the Lewy bodies make it difficult for the cells to function properly, and they're another reason for the symptoms that we see. Okay, so as I said earlier, cognitive difficulties are a common non-motor symptom in Parkinson's disease. So on this slide, I've listed the main cognitive domains or areas that are most often affected that I've observed in my clinical practice, and also that lots of research has shown. So I'm going to go through each of these areas in a bit of detail. So let's start off with something called information processing speed. So basically, this is how quickly one can complete a mental task, such as taking in information and then responding to it. So in Parkinson's disease, the thinking process does become slower. So it's not that the person is unable to think, but it's just that they need more time to process information and more time to answer questions or make decisions. So in terms of difficulties with processing speed that could cause problems in everyday life, some of the examples I get from patients are on the screen here. So things like, difficulty following a television program, because maybe the information is just coming in too fast to process. Also difficulty keeping up with conversations for the same reason. The information is just coming at you a little bit too quickly. Taking longer to make decisions or solve problems, or just in general being overwhelmed by too much information at once. Okay, the next one I'm going to talk about is attention and concentration. So this is the ability to focus attention and cognitive resources on a desired task, while at the same time being able to filter out distractions around you. And there's lots of different kinds of attention, some of which are listed here. Some of the difficulties I hear from patients are things like difficulty following a conversation without your mind wandering, right? Or maybe difficulty following this presentation without your mind wandering. So this is a problem in being able to sustain your attention. Another type of attention, selective attention. It's your ability to really select and focus on a particular thing at the same time tuning out all those irrelevant things around you. So an example of this would be having difficulty maybe doing a crossword puzzle or a task while the radio or the television is on at the same time. It's really hard not to be distracted by those other things around you. And finally, alternating attention or divided attention can be affected. And these are the kinds of attention you need when you're doing more than one task, kind of at the same time. And I often hear from patients that they feel their ability to multitask has been affected. So for example, being able to cook and have a telephone conversation with someone at the same time, having to divide your attention between the two things. Okay, the next one is called executive functioning. And a definition that I use for that is as follows. It's the ability to efficiently plan, problem solve, organize, and monitor behavior according to environmental feedback. And I often explain this concept by using the analogy of an executive or a CEO of a company. So you can imagine that the CEO of a company is the person that has to do all the planning and organization for the company. They have to really think things through. They have to anticipate problems that arise. They have to use good judgment in their work. And when things don't run smoothly, it's the CEO that has to do all the problem solving and troubleshooting to figure out what the solutions are. So, it's not just CEOs that need this ability, though. It's all of us in order to live our lives adaptively. So in terms of problems with executive skills, examples would include things like difficulty solving new problems that arise, and they could be just simple problems in your everyday life. Showing decreased judgment in making decisions, so perhaps being a little bit more impulsive or not thinking things through as well. Being less flexible or more rigid in your thinking patterns. Maybe having difficulty seeing someone else's perspective, or maybe getting stuck in a certain way of thinking. And another example would be difficulty generating or initiating new ideas or activities. So all of these issues could potentially impact things in our everyday life, such as handling financial matters, organizing and keeping track of appointments, knowing how to fix or repair something that broke down in the house, even planning things like trips and vacation. And even some aspects of driving are of an executive nature. So it can really affect a lot of things in our lives. Okay, and now I'd like to talk about memory. And this is, of course, a very important cognitive ability. And it's fairly complicated in that there's lots of different kinds of memory. But in a nutshell, I'm going to define memory as the ability to learn or encode new information and then be able to recall it or remember it at a later time. And memory problems aren't usually predominant early in the course of Parkinson's disease, but as the disease goes on, it is common to find problems with two aspects of memory in particular. So the first one is what I'm going to call efficiency of learning. And it's really difficulty encoding new information. So a person with this problem is going to be able to they're going to be able to learn new information, but it's just going to take longer to learn it. So in my practice, when I'm testing this, we usually give a list of words or a story, and we repeat it to the patient several times. And what we're really looking for is a nice learning curve, right? So we want to see that they get better and better at it as we give the lists out. And we often do see a learning curve in people with Parkinson's disease. However, the rate of learning and the degree of acquisition, how much they eventually get, is not as good as it once was. Okay, so essentially learning isn't as efficient as it used to be. And then the second type of problem is a reduced ability to retrieve memories or information that's been learned. So in Parkinson's disease, it's common that patients are going to have some difficulty remembering those lists or stories about 20 or 30 minutes later. However, if I give them a multiple choice format, they're going to do much better in recognizing the information. So that's what I mean by a retrieval problem. The material has, in fact, been encoded in the brain, and there are memories for the information, but the material is just not easily accessible to them when they need it. So in Parkinson's disease, people often take longer to learn new information, and they take longer to retrieve it or recall it after time goes on. And because of that, they often benefit from cues or reminders because this helps them to locate those learned bits of information in their brain. Okay, the next one is a bit harder to explain. It's called visual spatial skills. And these are a set of abilities that allow us to understand spatial relationships between things in our environment. And it actually involves a lot of different skills like visual perception, distance and depth perception, visual memory, visual attention. So a lot of different stuff goes into this ability. And real life examples of difficulties would be things like being able to put together a piece of furniture like from IKEA or something like that. So really understanding how things fit together spatially. Or difficulty following a pattern, when someone is knitting or crocheting or sewing, that could be another everyday example. Or even difficulty figuring out to read or use a map as well. Okay, the next one I'm going to talk about, the last one actually, is language. So compared to the cognitive areas that I've already discussed, language is somewhat less affected in Parkinson's disease. However, later in the disease, people can experience changes in language ability, particularly with respect to word retrieval and verbal initiation. So I'll talk about that a bit. So for example, word finding difficulties can become very common. So obviously this is when you can't think of that specific word that you're looking for, or the name of a person, or the name of an actor or movie. And of course, we all have this problem, right, as we age. So we know that with the aging process, word finding difficulties become a lot more common, but in Parkinson's disease, it can be more pronounced. And then there can also be changes in something called verbal initiation, and this really means your ability to generate or come up with verbal material. And this could result in kind of slowed responses during times in a conversation, because the person's finding it hard to quickly initiate an idea or keep up with the pace of the conversation. So as a result of this problem, sometimes people with Parkinson's disease don't seem as talkative as they used to be, or they don't contribute as much to conversations. I also have down here verbal receptive skills. So that's basically your ability to understand or comprehend language. And in the case of Parkinson's disease, this problem might be more related to slowed speed of processing again. So in other words, the person can't process the verbal information quickly enough to kind of fully understand it, especially if there's like multiple people in a conversation, or if the conversation is very quick-paced. So you might be wondering, when does the diagnosis of dementia come into play? So there's actually two main criteria for deciding when the cognitive problems qualify for a diagnosis of dementia. So first of all, there has to be impairment in at least two cognitive domains, so all the different areas I just talked about. And then second, the cognitive difficulties have to show a significant impact upon daily living activities. Okay, so for example, if an individual has some cognitive areas of difficulty, but they're quite independent in their life. They're still doing fine with complex daily tasks like keeping track of their schedule or remembering to take medications or being able to do financial management tasks. If they can do all of those things, then they would not meet the criteria for dementia. And we would probably instead say they have something called mild cognitive impairment, okay? And dementia, if it does occur, typically doesn't occur until later in the course of the disease. The average duration from the onset of Parkinson's disease to dementia is approximately 10 years, okay? But there can be wide variations in that. So some patients can develop dementia within a few years, and others it may take 20 years or more, and others don't develop it at all. Okay, so I'm going to change gears a bit here and start to talk a little bit about the emotional and behavioral changes. So if you remember earlier, I mentioned that there's important pathways in the basal ganglia that are connected to parts of the brain that control emotions. So therefore, it's not surprising that Parkinson's disease can be associated with changes in emotional functioning as well. And in fact, emotional or psychiatric changes are really quite common in Parkinson's disease. And most people, about 90%, will experience some form of mental health difficulties during the course of their disease. And this can include a long list of issues, but some of the more common difficulties are the ones that I have listed on the slide here. So I'm going to be going through each of these in more detail. Before I get into each of the different emotional problems, I just want to talk about the reasons why people have these problems. And there can be a number of reasons. So first of all, the problems can be directly due to the neurochemical changes in the brain. Okay, so things like depletion of dopamine that we talked about, but also depletion of other neurotransmitters as well, like noradrenaline, acetylcholine, serotonin, if any of those make sense to you. So that can be one, usually a pretty strong reason why people are having those problems. Secondly, though, sometimes it can be partially a psychological reaction to having a chronic illness, which is understandable. There's a lot of limitations that come with Parkinson's disease, so it could be a psychological reaction. And then thirdly, people with Parkinson's disease are often on a lot of medications, and therefore medication side effects can also be another reason for these problems. And finally, it could be a combination of all of the above. Usually there's not a simple explanation for it. So I'm going to talk about some of the emotional difficulties now. We're going to start with depression. So this is actually one of the most common emotional problems in Parkinson's disease, and as many as 40 to 50% of people are going to experience it at some point in their disease. The depressed mood can even be fluctuating throughout the day. So sometimes we find that in off periods when the medication has worn off, that is sort of the worst time for people. But when they take their medication, they tend to have a more neutral or elevated mood during those on times. Some of the common symptoms of depression are listed on the slide here. So having a very low mood and feeling sad, reduced enjoyment of life, loss of motivation and interest, even increased irritability or anger, feelings of hopelessness. Depression can also have an impact on many aspects of life, such as disturbing your sleep, affecting appetite and energy level, impairing cognitive skills, so that makes it even worse, and resulting also in social withdrawal and affecting relationships with people in their lives. Another quite common emotional symptom is apathy. So this is different from depression. So apathy can be defined as a lack of feeling, emotion, interest, and concern. So an apathetic individual doesn't act spontaneously very much, or they don't initiate a lot of activity. They may seem very indifferent to things around them. The person might appear withdrawn or aloof. They might seem uninterested in previously enjoyed hobbies or activities. And in most cases, a person who has apathy isn't even aware of it. It's usually the family members that become more aware of it than the patient. And it's really important to be aware that it's not the same as depression. So someone can be apathetic, but not necessarily be sad or depressed. And sometimes it can even be mistaken for laziness, but it's really important to be aware that the person with apathy doesn't have control over the problem. The apathy is often directly related to the degenerative problems going on in the brain. And it can be very troubling and frustrating for the families and caregivers as well. It can have a significant impact on the patient because they're less likely to be physically active, they're less likely to have social interactions with other people. It could contribute to problems taking medications, etc. Okay, anxiety. So like depression, anxiety is also pretty common in Parkinson's disease. And it can occur together with depression as well. Similar to depression, it's about 40 to 50% of people with Parkinson's disease are going to have some type of anxiety. The anxiety issues can be generalized, so something called generalized anxiety disorder, and this is when people are anxious or fearful for no particular reason. Or the anxiety could be more specific, like in the form of a phobia. And this is when it's tied to very specific situations or stimulus in the environment. Some of the symptoms of anxiety would include just feeling nervous a lot, worrying a lot about things, feeling jittery or restless, having a racing or unsettled mind, and even feelings of panic or panic attacks can happen. And again, like depression, anxiety can significantly interfere with everyday life and affect your quality of life as well. Okay, so let's talk a little bit about something called impulse control problems. So this is also pretty common in Parkinson's disease. The statistic I have is about 35 to 60% of patients may experience this at some point in their disease. So what I mean by this is with impulse control problems is there can be a tendency to have strong urges or compulsions that are really hard to resist. So for example, they can be in the form of compulsive gambling, compulsive shopping or eating, or sexual behaviors that are unusual for the person. There's also another behavior called punding. I don't know how many of you have heard of that one. Yeah, not too many. What this is it's a repetitive and excessive behavior that a person feels compelled to do. So the behavior doesn't appear to have any goal-directed purpose to it, and it could include behaviors such as sorting or counting or examining objects, sort of repetitively and excessively. So sometimes the behavior can be linked to a person's hobby or maybe their past job that they had. So some examples I came across in the literature would include things like somebody who just keeps examining and cataloging their jewelry over and over again, or someone who hoards flashlights and takes them apart and reassembles them over and over again. I know it sounds kind of weird, but these are kind of impulse control problems. I have to say that I haven't personally come across this problem very much in patients, but it could be that I'm not asking the right questions either. So it's just something to be aware of. And all of these impulse problems are thought to be due to medication effects, okay? So another type of impulse control problem is something called dopamine dysregulation syndrome. And this is relatively rare. Only about 3 to 4% of patients develop this. And it's the development of an addictive pattern of dopamine medication use. So with this problem, the patient will crave the medication and they'll self-administer doses of the medication that are higher than what is actually needed, okay, to control their motor problems. And a person with this type of problem might experience feelings of euphoria or increased activity when they're taking those extra doses, so it feels good. And then when the drug wears off, they might have the opposite feelings. They might feel very sad or anxious, etc. And this makes sense because dopamine is one of the neurotransmitters in the brain associated with the reward system, right? So it becomes very rewarding or pleasurable for people to take those extra doses. Unfortunately, this syndrome is very difficult to treat because you can imagine it's like a drug addiction, basically. So it's hard to treat, and it can be very disabling for the family and for the patient as well. Okay, another common emotional behavioral change is alterations in perception, and specifically hallucinations and delusions. So hallucinations are a false sensory perception, such that the person believes that they're perceiving something that's actually not there. So they can involve any of the senses, but in Parkinson's disease, hallucinations are usually of a visual nature. And some of the most common hallucinations are of small animals or children. And they can be pretty common in Parkinson's disease. So about 50% of people will experience hallucinations at some point. In contrast, a delusion is a strongly held belief that isn't true, and it's not based on reality. So delusions are generally less common in Parkinson's disease. The statistic is about 30% of people. Examples of delusions, common ones would be a fear that someone's trying to harm you or steal from you, or that a spy is living in your neighborhood, those kinds of things. And it's usually a very strongly held belief, and the person will continue to believe it despite the fact that it's highly unlikely to be true. And finally, vivid dreams or nightmares can also occur in Parkinson's disease, and it might fit into this category of perceptual alterations as well, but that's during sleep, of course. So it's important to know that many of the emotional changes can be treated and even reversed, okay? And there's lots of options for treatments. So first of all, with a lot of these things I've mentioned, there are medications that can be helpful to alleviate the problems, but it's very important to know that patients with Parkinson's disease and older patients in general can be very vulnerable to the effects of what we call psychotropic medications that are used to treat things like anxiety and depression. So some medications for depression and anxiety can actually have adverse cognitive effects on cognitive functioning, so making that even worse. Some of the medications to help with hallucinations can make the motor symptoms worse. So it's really important that the treating physician has to do a very careful review of all of the existing medication that a patient has, and ensuring that if they add the new medications, it's not going to make things a lot worse. Psychotherapy and counseling can also be helpful to patients to help them cope better with the emotional changes. And therapists can suggest strategies and techniques to help patients cope better. They could be things like relaxation training, meditation, breathing exercises, etc. Education and support groups are also very helpful. So simply gaining knowledge about the problem and realizing that other people have that problem, that in and of itself can be therapeutic for people. Exercise. I'm going to talk about exercise later in my talk in more detail, but there's evidence that exercise can result in significant improvements in mood and emotional functioning. So I would include that as a treatment. And also just improvement of sleep and diet and those kinds of things can also help with emotional issues as well in some cases. Okay, I'd like to talk now, say a few words about deep brain stimulation. I'm going to talk about it mostly from the perspective of neuropsychology, because I'm frequently asked to assess people who are being considered for the surgery. But first, a bit of general information. The surgery essentially involves implantation of an electrode at a certain targeted site in the basal ganglia. And as you can see on the slide, the electrode is connected to a neurostimulator, which delivers electrical impulses to the target electrode. And this results in improvement of the motor abnormality. And after the surgery, the stimulation can be very fine-tuned and adjusted for each individual patient so that it works the best for that particular patient. And even though deep brain stimulation is generally considered a pretty safe procedure, there are risks involved, of course. So things like stroke, other bleeding in the brain, seizures, as well as impact on cognitive functioning and emotional functioning. So because of that, we want to make sure people are the right candidate for the surgery. So because of the risks, there's some general criteria that neurologists and neurosurgeons use to decide if a person is a good candidate. So the first one is that there has to be a firm diagnosis of Parkinson's disease. So they want to make sure the person really does have Parkinson's disease, and the symptoms have to be clearly responsive to the medication. The motor symptoms, the primary motor symptoms, should be pretty disabling in order to have the surgery, and they really have to impact the quality of life for the patient. The third thing is that the medications generally aren't working the way that they used to. So maybe a dose doesn't work as long as it did in the past, or maybe there's something called sudden wearing off of the medication where people suddenly freeze and they can't move. And the other major aspect is that when people have been on the medication a long time, when it is working, they develop these other motor movements called dyskinesias, which can also be extremely disabling and interfere with their everyday life. And finally, in order to be a good candidate, the patient shouldn't have any other critical illnesses or brain dysfunction because of other things like Alzheimer's disease or maybe another neurological problem. And from a neuropsychological perspective, when I see patients, these are the kind of criteria that I'm looking for. So generally speaking, we would not want the person to have a dementia. We want them to be functioning relatively well from a cognitive perspective, and there's a few reasons for this. So first of all, we want the patient to have good decision-making capacity because they're undergoing a brain surgery. We want to make sure they understand all the risks and benefits. Secondly, the patient is awake during the surgery and they have to be able to respond to the neurosurgeon and be able to understand what they're saying. So it's also important that they're able to do that. And third, we know from some of the research literature that patients with dementia are at a greater risk for further cognitive impairment following the surgery. So we certainly don't want to make things worse for them that way. However, having said all of this, simply having some cognitive difficulties doesn't rule out the surgery. In fact, many patients I see have some cognitive impairment and then they go on to get the surgery. The second sort of thing I look for is that the people shouldn't have significant mood or psychiatric illness as well. Because again, severe depression or anxiety or significant impulse control problems can make things worse after the surgery. So there's negative outcomes associated with these things. So, but again, because depression and anxiety are so common, we certainly wouldn't rule people out for the surgery if they have mild symptoms in those areas. I also look to see if people have good psychosocial support when we're considering them for the surgery. So family members or friends are needed that can be with the patient over that immediate pre- and post-surgical period, and also be there to assist them when they go home, and they have to come back and forth to the hospital many times to get lots of adjustments to their stimulator. And finally, I want to make sure people have reasonable expectations for the surgery, because it's not a cure. It's certainly going to improve things, but it's not a cure. And we want to hear from patients that they appreciate all the benefits and also the risks of the surgery as well. Okay, so I want to end on a positive note and give you some very basic advice regarding what you can do to maintain optimal brain functioning. There has really been an explosion of research in the past decade or so about lifestyle changes to reduce the risks of dementia and to keep our brains as healthy as possible. So prevention, in a way, has almost become like a type of treatment. And with this research, there's been a huge number of risk factors identified that are believed to contribute to problems with brain functioning and development of dementia, particularly as we get older. So just to give you a quick idea, I'm going to list some of these risk factors for dementia, okay? Age, not much we can do about that one, unfortunately. Physical inactivity, obesity, poor nutrition, diabetes, high blood pressure, medication effects, smoking, high cholesterol, excessive alcohol consumption, hearing loss, concussion or traumatic brain injury, mental health problems, and sleep problems. So this is not even an exhaustive list. So the bad news is that there's a lot of risk factors for cognitive impairment, and some of them you can't do anything about, like getting older. But the good news is that many of these factors are related to our lifestyle, and therefore they can be modified. So because of time constraints, I can't go into all of them, but I am going to focus on 3 of them: exercise, social activity, and mental stimulation. And they're all particularly promising for fighting cognitive decline and keeping our brains healthy. And I should emphasize that paying attention to these factors is applicable to all of us, whether or not we have a neurological disease. And some research indicates that these lifestyle factors can even benefit people who have cognitive impairment or dementia as well. So it applies to everybody. All right, so first and foremost, exercise. It's certainly good for us to be it's good for us physically and even for our emotional health, but it turns out that it's also excellent for us cognitively. So many studies have shown improvement of cognitive functioning in older people who exercise, and there's a lot of evidence now that links regular physical exercise to decreased cognitive decline and reduced risk of dementia. Even with regard to Parkinson's disease, there have been quite a few studies done showing that cognitive abilities such as executive functioning, attention, and memory significantly improve in people who do strength or resistance training or aerobic exercise. And studies have shown that aerobic exercise in Parkinson's disease actually increases the release of dopamine in the brain, which is exactly what's needed. So, and it certainly doesn't have to be marathon running, okay? So even increasing your exercise beyond what you're doing now is going to help. So regular walking, etc. Other suggestions, could include things like swimming, water aerobics, yoga, resistance training, Tai Chi, anything that you like and enjoy. That's the important thing. You have to like it for it to work. And I know that organizations like the Parkinson Society are often able to provide a list of exercise classes that are offered in the community, so you can check those out. Social activity. So it turns out that staying connected and engaged with other people also helps your brain. So if you think about it, when you're with other people, you have to listen to what they're saying, you have to think of an intelligent response, and you have to interpret social cues that are happening. So it's actually a cognitively demanding activity. It challenges your brain, and it also helps with mood and emotional well-being if you're around people that you like. Certainly the people in this slide seem to be having a good time, so social activity is important. Finally, mental stimulation. So many studies have also shown that older people who keep mentally active show a reduced rate of cognitive decline and reduced risk of developing dementia as well. There's even some studies that show that doing mentally stimulating activities can increase neural connections in the brain and increase overall brain volume too. So that's quite amazing. And we've all heard the term use it or lose it, and that applies in particular to this. Some examples of mentally stimulating activities would include playing challenging games, joining a book club, taking a community course, learning to use a new computer program, etc. And the key really seems to be it's better to do multiple and varied tasks instead of just one thing. And once a task becomes too easy, then it's not probably challenging your brain, so you should mix it up and try something else. So these activities should really make you think and make you engage your brain. And I want to say that when you're considering how to incorporate these lifestyle changes into your life, try to think about finding activities that combine two or more types of stimulation to get the best bang for your buck. So for example, if you're joining a senior center, you're likely to have all three of these things. There's likely to be exercise programs, social activity, cognitive stimulation. Or doing group exercises combines two things, the exercise and the social activity. So that brings me to the end of my presentation, and thank you very much. It was really a pleasure to speak to all of you this morning. Thank you.